Uh, I am a nephrologist. That is the first disclaimer I would like to give. But the topic I'm going to talk about is relevant to both hepatology and nephrology. So I'm going to be speaking about a prospective study that we have done to analyze the accuracy of estimated GFR equations as compared to measured GFR by iohexol plasma clearance. So we do know that renal impairment affects the morbidity and mortality in cirrhotic patients significantly. Almost 80% of the patients have some sort of a renal issue during their course. The earlier studies on GFR estimation, which were used to validate the equations and all, did not include cirrhotic patients and are especially erroneous in this population subset because of the fallacies associated with creatinine and urea. So, whenever a patient has low muscle mass, increased volume of distribution, low albumin, hyperbilirubinemia, then their creatinine will be fallacious. Malnutrition adds to the trouble and adds to inaccuracies. Urea, on the other hand, because of GI bleed, can be elevated. Now, the measurement of GFR. So, all these formula are estimation of GFR by using some sort of a biomarker. So, what we did was we measured GFR. And how we did this was giving an iohexol injection, which is actually the same as your CD contrast, but a very, very small dose at baseline. And then we have taken time samples. We'll discuss that in the methods. So the most important thing is that it is ethnicity specific. GFR varies. The formula are also corrected for different ethnicities, and we don't have Indian data. So that's what our objective was, to look at how accurate these equations are in our population with cirrhosis. So it was a cross-sectional study, and it's an ongoing study. These are the pilot results. We had included adult patients with creatinine of less than 1.9. We excluded the ones who have any form of acute kidney injury, any form of acute kidney disease, any dialysis dependence, malignancy, pregnancy, or if they had any history of allergies to iodinated contrast media. So we took them from our hepatology OPD and we admitted them for half a day. I collected baseline samples for creatinine and LFTs. Then iohexol injection was given and time samples were taken 1 hour apart. They were stored at -80 and later on processed by HPLC for their concentrations. The baseline sample stored was also used for estimation of cystatin C. So these are the results. This is a pilot data of 34 patients, the initial 34 that we enrolled after standardization and validation of our technique. ALD constituted 20, that is majority of the patients, and the other contributions were from patients with hepatitis B, C, MASLD, and some overlap. So the average creatinine of all the patients enrolled was 0.8 plus minus 0.2. That's near normal creatinine, and the measured GFR we found was 73 plus minus 10. Let's look at the baseline characteristics somewhat. So the age is around 50 years of age. And as you can see by weight, most of the patients actually did not have a poor BMI. They were not very wasted. And as you can see in the last but one row here, the child buck stage was 5.9 as an average, which says that we had taken well-compensated cirrhosis. The main reason for this is we wanted relatively stable patients who can actually undergo the procedure in the initial phases of our study. So their sodium also was relatively well preserved, as you can see here. So was the INR and the albumin. Okay. Now this is the basic results slides that I have. I would like you to see, we have arranged this in the order of the accuracy. So we'll first look at this last column. This shows how many patients actually fell within 30% of the measured GFR value. How many eGFR equations that is. So CKD EPI by creatinine was the most accurate one. Sorry, here. 79, so close to 80%. But whenever creatinine was added to the cystatin C, its accuracy reduced. And the creatinine-based equations, namely the MDRD4, MDRD6, CKD-EPI, these were all very less accurate, with less than 40% of the values falling within 30% of the iohexol GFR. And the mean bias is actually the difference between eGFR and mGFR, this column here. As it shows, it's least with cystatin C and cystatin C with creatinine. But when it comes to creatinine, the bias can be to a tune of 30 ml per minute per 1.73 meters square. So this is the graphical representation. So these scatter plots are all the GFRs, and mGFR is here on the x-axis. And you can see all the creatinine-based ones are out of this P30 range, while in the cystatin C, most of them do fall. So what do I conclude from this? Creatinine-based equations are imprecise and less accurate in Indian cirrhotics. The accuracy is in this order. Use cystatin C when you need more accurate values, and cystatin C plus creatinine less accurate. And in routine care, creatinine based, but you have to know that it is not going to tell you GFR in most cases. Literature says that MDRD4 and MDRD6, which were specially developed for cirrhotic patients, perform better, but no, they don't in our study. These are the limitations. This was a small number, and these were relatively normal creatinine values. So we do need large-scale data in our population to determine the correction factor in our Indian population with cirrhosis. These are my acknowledgements. It's an ICMR-funded study, and it's an ongoing study. I would like to acknowledge my collaborators from hepatology and from my head of nephrology, Dr. H.S. Kohli, and my entire team, including Ms. Kanchan, who's right here. Thank you. Almost all, sir. And we did not stop them before procedure because that would be their GFR, the GFR that is on the diuretics, and we wanted the GFR that is while the patient is on their present medication. So almost all of them. No, sir. Most of them did not have. I'm sorry, sir. Many of them had a history of having ascites at some point of time and some edema, pedal edema, and the diuretics were being continued in most of them. Most of them, yes, sir. If in the presence of ascites, most of them were compensated cirrhosis, sir. So we have not done anything for the study as such. We have not interfered with the management. We have only noted whether they were on it or not and what was the dose, but we have not modified anything since we only are doing a research procedure for sort of analyzing the GFR. We did not want to alter anything in this study. So, not all of them, sir. I have not presented that data here for the want of time, but half of them were on beta blockers as well. You can. I completely agree with this, ma'am. In fact, as I said, this was the initial stages where we actually found low GFRs and we were baffled. So this is an ongoing. Yeah. This, ma'am, is an ongoing study. We do not have a last message yet. So we will have patients in all stages of cirrhosis as well, and especially the ones the intention was to do in them. But because it's a new procedure, we do not know how the patients will tolerate it, especially cirrhotics. Our institute does this in normal patients and CKD patients, and there's no trouble. But with cirrhotics, even doing the procedure is trouble. Almost 10% of them we had to exclude because they developed hypoglycemia. They could not stay NBM, which does not happen in other patients. So they had to be NBM because anything taken orally can also affect GFR, be it protein, be it glucose, which is why for initial validation we have chosen that subset of population. So this is more of a technical reason at this point of time, because if the GFR is too low, then the iohexol clearance will take more than 24 hours. So it's more of logistics. We'll have to admit a patient for more than a day for advanced creatinine. I agree. In the end, when we have about 300 patients, we will do subset analysis as suggested by you. That's a plan. We will separate the patients which were so called normal creatinine and analyze the accuracy of that. And then the advanced, and actually in advanced renal dysfunction, there isn't so much trouble. Somebody with creat of 3, everyone knows has renal trouble. Our thing is to find out whether this has an impact, whether our lower GFRs also has an impact. So this will need observation over the years and probably 3 4 years, even beyond the study. Actually, yeah, this the full manuscript actually has it. I am hoping that you guys accept it so that we all can read it. It is submitted to the JECH. I will definitely try to look into it. It's an ongoing thing. Your inputs will be very helpful. Thank you, sir. Thank you, sir.